DCB stent platform. This is just an update on clinical programs. So I will go very briefly concerning the technology, because I'm pretty sure that you will know very well what I'm talking about. The Luminous Desk is a cobalt chromium stent system specifically designed for diabetic patients. And in Europe, it has been approved for diabetes as well as for acute myocardial infarction. So the Luminous is designed to treat diabetic patients with M-Visualization technology. This is actually made to overcome the limitation of current DS concerning, in particular, the risk of stent thrombosis, in-stent restenosis, but also the delayed vessel healing, which is the basis of both events, leading to cardiac death, target vessel MI. As I said, I was actually just touching briefly the technology features, and the Luminous Desk Plus is actually pre-cream, as characterized by a pre-creamed coating, an abluminal coating, and is also meant to address the focal restenosis, because both the stent as well as exposed parts of the balloons are coated, which increase the surface area, hence increasing the drug delivery. But also the problem of the edge restenosis has been addressed by means of 0.5 millimeters or coated both ends of the stents. And this is just comparison. You have seen that several times with other stents in terms of struct thickness, and these are just the technical specifications you can find everywhere. So let's go to the point of this. So the clinical program has been extensive, and it started a few years ago with the ENABLE-1 study, and then progressed with the ENABLE registry, the dedicated registry, which is ongoing, and we'll see also the ability randomized control trials and the ability global. So the very first experience was made as a first-in-man clinical evaluation of Luminous Desk Plus for the assessment of safety and efficacy in treatment of coronary artery disease. Dr. Samerdani was the principal investigator. These are the results. This was a first-in-man clinical evaluation, and of course, a very small group of patients. The design was relatively simple. Prospective single-center randomized clinical trial, and the primary endpoint, the in-stent late luminal loss at 6 months, evaluated by means of QCA. Some other secondary endpoints, including clinical endpoints, but of course, the trial was not powered for clinical messages. These are the results. As you can see immediately in the left side of this slide, the percentage of patients with diabetes were absolutely high, as conceivable of population coming from India. But also the complexity of the lesions was relatively high. And these are the results of the QCA at 6 months. As you can see, the late lumen loss in segment was 0.17 plus minus 0.2, and late lumen loss in stent was 0.24 plus minus 0.3. The clinical follow-up, as I said, was 2.5, 12 months, very encouraging, but of course, just hypothesis generating. The ENABLE e-registry was a post-market registry of Luminous Desk Plus sirolimus eluting stent. And again, Dr. Dani was the principal investigator. So the objective here was to evaluate the safety and efficacy of the Luminous Desk Plus in an all-comers population with minimal exclusion criteria. The study design was a larger design, multi-center, prospective, all-comers ongoing registry performed across 31 centers in India. The primary endpoint was major adverse cardiovascular events, such as a composite of cardiac death, target vessel MI, target lesion, target vessel vascularization, 1-year follow-up, with some secondary endpoints, including stent thrombosis. These are the results: 2,500 patients, and completed almost 100% of them completed 1-year follow-up, including those actually having a fatality, and 2 years follow-up was completed by 89% of the patients. And these are the results, as you can see at 1 year. So more than 2,400 patients. The red maze was absolutely encouraging because, as you can see here, the percentages are quite low, and these percentages were consistently low for cardiac death, target vessel MI, TLR, TVR, and stent thrombosis. So it was very, very good clinical performance. But some group analysis have been done, in particular with a maze rate at 1 year. So the analysis suggested there was no significant difference in maze across all different subgroups, except small vessel, multivessel disease, and overlapping deaths. I would like to draw your attention in particular to the very first row of this table, patients with diabetes versus patients without diabetes. So there was no significant difference. And this signal was actually used for other studies we will see in a minute. So let's have a look in other more details at this first row of the table. So if you compare directly patients with diabetes versus patients without diabetes, you'll see that there is a very slight difference in terms of MACE, suggesting that the Abluminous Des Plus had a very, very nice performance, even in patients at very high risk, talking about diabetes, of course. And this, of course, when you compare with the performance goal, is very, very encouraging, but again, hypothesis generating. But if you look at other aspects of this large registry, we'll see that, for example, the MACE rate and stent thrombosis at 1 year was absolutely consistent, even if you compare the two populations of patients coming with acute myocardial infarction versus patients without acute myocardial infarctions. Even in this case, there was a very powerful performance. The dedicated registry is drug-eluting stent for diabetic patients in coronary artery disease treatment, and I'm also very proud to be the principal investigator in this. The objective was to capture clinical data of the Abluminous sirolimus eluting stent in real-world all-comer patients with diabetes. So for the first time, this trial, this registry, has been conceived to address specifically patients with diabetes. The primary endpoint was a target lesion failure, that is a composite of cardiac death, target vessel MI, and clinically indicated target lesion revascularization within 12 months, and a full list of secondary endpoints. This is the study schedules. I will go over briefly. And at the moment, there are several target sites including, but this is the situation so far. So 1,393 patients enrolled, with, of course, a large amount of patients enrolled in India. The Ability randomized control trial was a randomized clinical trial of Abluminous Des Plus versus everolimus eluting stent for percutaneous coronary intervention. Investigator-initiated pilot study. Two my good friends are the principal investigators, Dr. Latib from New York and Dr. Antonio Colombo from Italy as well. The objective was to compare angiographic and clinical performance of the Abluminous Des Plus versus the everolimus family, but the study design was slightly different as compared to previous experiences, multicenter single-blinded in 7 Italian sites, and diabetic patients undergoing percutaneous coronary intervention randomized in a 2-to-1 ratio, total of 165 patients. The primary endpoint was in-stent neo-interval volume at 9-month follow-up, measured by means of OCT following PCI. Secondary endpoint, again, a full list. These are the participating sites, as I said, 7 sites in Italy, and this is the situation. 149 patients already enrolled. And this is obviously the last kid on the block, but actually the largest ever. So, the Ability Diabetes Global. Randomized comparison of Abluminous Des Plus sirolimus stent versus everolimus eluting stents in coronary artery disease patients with diabetes. Even in this case, there is a very large executive operation committee and a large steering committee, which I'm part and proud of being there. And this is the breakout of the study. Of course, it will be at a global level, and it's still obviously ongoing. So in particular, you see that there's a randomization based on clinical and angiographic inclusion-exclusion criteria between Abluminous Des Plus and Excience family. And of course, the objective is to compare the efficacy and safety of Abluminous Des Plus versus the everolimus family in diabetic patients eligible for PCI with minimal exclusion criteria. Secondary endpoints, of course, is again a full list of other endpoints. And of course, I'm going very, very fast to the end of this presentation. The Ability Diabetes Global will give a final answer to the actually signals that we have seen in the previous experiences. Of course, this is ongoing and this is very ambitious, and this is the largest ever trial specifically concerning diabetes. So stay there and see what happens with the clinical data coming from this large randomized controlled trials, again, already performing this very ambitious design in all around the world. Thank you very much for this.
Thank you very much, Luca. If there are any questions or any comments, I can see.
Yeah, it's a unique concept and extent and a very good innovative design of the stent. Especially it's a DES which is mounted on a DEB. And two important things which I find it very, very useful is a edge coating of the stent, which definitely reduces the chances of edge restenosis, and the fusion coating, where there is homogeneous drug delivery to the entire length of the lesion. so that the geographic means and everything. So the chances of restenosis will be much less. So it's a very, very innovative idea, unique idea to see the trial results and the dedicated registry results. Thank you.
Luca, I would just like to ask you, you have a lot of experience with this stent design. Would you, so many diabetes patients have a diffuse changes. There's a lot of plaque material which we not see by angio. And usually we have also some resistance if we try to cross with stents to the target lesion. What would you say if you compare, let's say, Abluminus newest version with Synergy or Zyro? Would you say it's a very similar or even better in cross comparison?
That's a very good point, because initially, well, at the beginning of my experience, honestly, I was afraid about paying a price in terms of pushability and trackability because of these features. And to be honest, I had a chance to challenge the Abluminus Des Plus in every single situation. And I mean, there is a very, very, let's say, minimal trade-off. So what I mean is, in, well, let's say extreme tortuosities, in extreme calcified long lesions, there is a price to pay. But it's actually something that we all know, in particular from the experience coming from the DCBs. So we know that the DCBs technologies are, in that perspective, let's say, less performance than as compared to last generation, last iteration of DES. So overall, I would say there is a very small price to pay. However, the concept of merging the features of a DCB and a drug-eluting stent is something very interesting, in particular for exactly the situation that you mentioned, the diffuse disease and the need for homogeneous drug delivery and for possibly treating longer vessels, longer lesions. Of course, I don't have a final answer. We are producing the data, so we'll see.
Yeah, we're participating in this study. It's a great study. Thank you.